radiotherapy for benign conditions. So it was introduced as for benign tumors, but actually there's plenty of things that are not tumors.
Sorry, Richard, can you make it full screen, please?
Yeah, yes, I can try.
Yeah.
One moment. It was going wrong before, but I can see if it goes right now. That doesn't seem to be correct. Is that better?
Okay.
Yes?
No.
Well,
It's the same thing.
it's the same thing.
Okay. I don't know why it's not working.
F5.
Okay, F5.
Okay, I'm sorry. Yeah, I'm sorry about that. What I might do is just make it slightly larger, so that it's as big as it can go. There we go. All right. There we are. All right. So hopefully that's as big as it can go. All right. So I was just saying that it was introduced as being radiotherapy for benign tumors, but in fact there are lots of conditions that are not tumors. But if we just go through the categories one by one. So the first category is hyperproliferative. So essentially, the way I describe this to patients is that it's overgrowth of benign tissue. And the main conditions here will be Dupuytren's disease of the hand, Ledderhose disease of the foot, which is lumps on the feet, which is like Dupuytren's disease of the hand, but causes pain rather than curling of the fingers. Keloid scars, pterygium, those are the main ones in the hyperproliferative conditions. And we use a sort of intermediate dose of radiotherapy, and you can use various techniques. So you can use the superficial orthovoltage machine, you can use megavoltage or electrons. The next group is the degenerative and inflammatory, and really this is very low dose radiotherapy. We'll go through this in some detail. And the main conditions here are osteoarthritis, tendinopathy, and bursitis. And again, you can use orthovoltage or megavoltage, generally not electrons. There are quite a number of inflammatory skin conditions that you can treat. This is not something that's done very widely. It is done mainly in Europe, particularly in Scandinavia. And things like difficult to treat psoriasis, particularly on the scalp, on the palms and the soles, hand and foot eczema, and various other rare conditions, including DSAP, which is disseminated superficial actinic porokeratosis. And we use low to intermediate doses of radiotherapy, but importantly, we use quite low energies of superficial X-rays at the sort of 10 to 50 kV range, 10 kV being called Grentz rays. I'm sure you've all heard of the stereotactic indications, and of course there's plenty of intracranial indications, including things like meningiomas, acoustic neuromas, trigeminal neuralgia, and so on. And there's a new techniques for treating particularly ventricular tachycardias, so cardiac arrhythmias. And this, of course, is a high dose perfraction, very focused X-rays, very complex, using stereotactic techniques. And then there's this sort of whole other bucket of conditions which are not the same as each other, but that includes heterotopic ossification, so new bone growth outside of a joint, Graves or orbitopathy, PVNS, which is pigmented villonodular synovitis, which is overgrowth of the synovium, and sialuria, which is too much salivation, particularly in patients with Parkinsonism. And of course, these require different doses and different techniques according to what the particular conditions are. So I think let's just make it a little bit smaller. So this is just a scheme of the sort of musculoskeletal radiotherapy indications. And really in the classification, that was the first and the second. So in other words, the hyperproliferative, but mainly the very low dose radiotherapy indications. And you can see that for different parts of the body, there are different things that you can treat. So for instance, on the hip, The main ones there would be one thing that's called Cox arthrosis, which I normally call hip osteoarthritis. But there's also a bursitis and tendinopathies, which you can treat there. On the hands, the main things that you treat there really would be Dupuytren's disease, which is the hyperproliferative condition, and osteoarthritis, either at the base of the thumb or the other thumb joints. So it does vary according to the anatomical site. Now, the Germans are the ones that do an enormous amount of this. And they did a study in 2018, which was a patterns of care study, looking at all their centres. About 1 in 3 returned a questionnaire, and that got them to more than 35,000 patients per year. If you extrapolate for the whole of Germany, then it's at least 100,000 patients a year, although anecdotally it's probably more like 200,000 patients a year. And you can see that's in a population of 83 million people, that's an enormous proportion of patients who were treated. Just going through the mechanisms of the doses again, so the anti-proliferative dose would be roughly 20 to 30 gray, let's call that intermediate dose, and the anti-inflammatory dose would be 3 to 6 gray and 6 fractions, so let's call that low dose radiotherapy. And most of the radiotherapy that was delivered for benign conditions was for the low dose radiotherapy group, that's the degenerative and inflammatory group for osteoarthritis and tendinopathy. There's certainly increasing worldwide interest. You can see that, I mean, this is just a rough thing that I did over the last week. You can see that most of the interest is in Europe, but Australia currently are doing a randomized controlled trial for radiotherapy for early Dupuytren's disease. And in particular, the US are really starting to take notice. And I've been speaking to the president of ASTRO, and they want to make this one of their 3 priorities for 2025 for the meeting. So they're really taking this quite seriously as a sort of growth idea. So how does it work? Well, again, it depends on the particular condition. If we're talking about low-dose radiotherapy for osteoarthritis, this really works best as a single dose of 0.5 gray per fraction, which is also obviously very, very different from the sort of anti-proliferative doses that we used to using at roughly 2 gray per fraction or higher for cancer. And it actually does not have an anti-proliferative mode of action. It's mainly an anti-inflammatory, but also has action on bone cells. So, you know, in inflammation, normal inflammation, you get the white cells, the leukocytes that would adhere to the endothelial cells. They're recruited, they come to the inflammatory stimulus, and they work together with macrophages to create an inflammatory environment. And radiotherapy works on all those cells. So it stops the white cells adhering to the endothelial cells. It modulates the secreted cytokines. It makes the macrophages into a less inflammatory type of macrophages. So that's this sort of anti-inflammatory part. But it also has direct actions on the osteoclasts and the osteoblasts. And it reduces bone resorption, and it induces mineralization of the bone. So there's quite a number of different actions that it has in osteoarthritis. But then when you go to the anti-proliferative conditions, such as Dupuytren's, then again, this is a very complex process. In Dupuytren's disease, the main cell that is active is the fibroblast. And essentially, Dupuytren's is excess scar tissue underneath the skin. And radiotherapy reduces fibroblast differentiation and stops it giving off the scar tissue. It only really works when there's biological activity in the early stages. Once it forms a contracture, it's no longer really effective. So there are very different actions, and this really is given at 3 gray per fraction. So obviously it's very different mode of action and a different dosing schedule. So this talk was done for the US, and you can see in the US that you know, around 1/10 of the population suffer from osteoarthritis. There's a large number of people who suffer from keloid scarring. Around 10% are affected by plantar fasciitis, that's heel pain. and roughly 2 to 5% suffer from Dupuytren's disease of the hand. So we'll go through those very shortly. I'm not going to go into too much detail, but I'm very happy to answer any further questions about these. So I don't know how much Dupuytren's disease there is in Nigeria, but it's fairly common in the UK, particularly in the north of the UK. And essentially you get nodules and cords in the palm. These then worsen and the cords go into the fingers, and eventually the cords contract and form these fixed contractures. And when that happens, you really need surgery to release those contractures. Radiotherapy is used in the early stages when you have nodules and cords, but either no contracture, so no fixed bending of the fingers, or a very minor contracture of up to 10 or 20 degrees. And it's able to reduce the chance of forming a contracture by 3 times. So as I say, it's in the early stages. The evidence is pretty good for this. It's not a randomized controlled trial. There is, as I say, one going on in Australia at the moment, but there is a non-controlled trial where they compared the outcome of patients having radiotherapy with the outcome of those who didn't have radiotherapy. Osteoarthritis, I think, you know, for me, feels like the biggest growth area. Clearly, it's extremely common. Really, it's whole joint failure. And, you know, essentially in the early stages, people are told to exercise, lose weight, maybe take some anti-inflammatory or pain-killing medication. As you go further along, they might have injections into the joints. But really, then there's this whole space until they need a joint replacement where people are in pain and there's nothing really that helps. And this really is where I feel that radiotherapy can have its most effect. As I say, we use a very, very low dose, a total dose of 3 Gray and 6 fractions, given over 2 to 3 weeks. Very simple techniques using a parallel pair. And depending on the sites that you're treating, overall, it will give you a 70 to 75% chance of relieving pain. So I think this, for me, is an area that could really help an enormous number of people without too much of a risk of causing side effects. Obviously, you need to choose your patients. You're not going to treat young patients, and it really is only osteoarthritis, not other types of arthritis. Plantar fasciitis, an enormous number of patients, as I say, 1/10 of the population, and this is due to strain and overload of the plantar fascia. For instance, due to being overweight or wearing poor footwear or doing too much physical activity, causes pain in the heel. And most people have conservative treatment. And, you know, so basically resting, stretching, icing, wearing better shoes, that sort of thing. And it tends to get better. But there is a cohort of roughly 20% of people where it doesn't get better. And there aren't really great treatments. You know, so people do have steroid injections. It can give a bit of short-term relief, but it's not a long-term solution. There are other types of injections called PRP or platelet-rich plasma, which perhaps are effective. Shockwave treatment that's very available in the UK, which is quite painful. The evidence is not brilliant, but it may be effective. Surgery, of course, is invasive and has various risks and requires recovery. And radiotherapy, again, can be used in very low doses of 3 to 6 Gray and 6 fractions. Of course, it's non-invasive. At that low dose, it doesn't cause any side effects, although if you're treating relatively young patients, you do need to think about the risk of radiation-induced carcinoma. We can go into that in some detail if you like. But this really does help 4 out of 5 patients. So I found this to be very effective and patients are very grateful. I suspect this is one that you're treating a fair amount, keloid scars, and they can cause significant cosmetic impact. Really, I find that radiotherapy is not helpful for the primary treatment of keloid scars, and I just use it in the post-operative setting. As I'm sure you know, you have to give it ideally within 24 hours of the surgery. You have to think about, again, the risk of radiation-induced cancer, particularly if you're treating young patients, and particularly if you're treating over areas like the breast or the thyroid. And also, I tend to use a risk-adapted approach where, for instance, on the earlobes, you can lower the dose, and in high-risk sites such as the chest and the shoulders, you'd be looking to increase the dose. so that you can get a good reduction in recurrence rate. So, I mean, I guess one question might be, well, why isn't this done more? And I think that the reason why this is underused for benign conditions is pretty complex, actually. You know, I think part of it is that in any country, there's rationing of health resources. In the NHS, our linacs are very full. So there is a certain amount of rationing. There's certainly a lack of education and loss of transmission of information. People don't really know about this, and they have a certain amount of sort of fear of doing new things. I think certainly I see in the States and in the UK that people are really keen on doing new, expensive and complex things. So we were talking about stereotactic radiation for cardiac arrhythmias. That seems to be a really big thing at the moment. But, you know, sort of simple, experience-based, cheaper things, it's sort of not quite as glamorous and people aren't quite as interested. But I really think that's where, you know, massive value lies. You can really do a lot of good in terms of quality of life for these patients. There is a lack of randomized controlled trials in the literature. There's an enormous amount of case series evidence, and I think that you know, that needs to be improved. I think there is an issue with naming. It might be this slide is too small, but of course, you know, I'm called a radiation oncologist, and oncologist means I'm a cancer doctor, and we feel that we are lifesavers, and that's true. But I think that stops us from thinking of ourselves as radiation specialists or radiation physicians, where we can also be allowed to affect people's quality of life and also treat non-cancer conditions. People do worry about safety, and I think that's very reasonable to worry about, but people certainly overestimate the risk of radiation-induced cancer. So for instance, if I'm treating a patient with Dupuytren's disease of the hand and treating most of the hand with electrons, then for a 50-year-old, I would say that they have a 0.1% lifetime risk of a basal cell carcinoma. There's no red bone marrow there, so there's no risk of leukemia. And of course, it's just a local treatment. So I think people rather overreact. Of course, there are areas where we need to be careful. We've talked about treating over thyroid or breast. And there have been disasters in the past. For instance, people treating ankylosing spondylitis with radiotherapy and an increased risk of leukemia. So clearly there are areas that we need to avoid. I think also people underestimate the risk of other treatments. So for instance, in osteoarthritis, people often are on non-steroidal anti-inflammatory drugs like ibuprofen or naproxen. And of course, those have cardiac side effects and gastric side effects. And people tend to underestimate those side effects. So for the future, you know, I think there's a lot that we need to do to change culture. Just going in not too much detail, we do need to improve the evidence base. I really feel that randomized controlled trials needs to be the standard. The Germans have done an enormous amount of publication, but they tend to do it in their own German journals. We need to develop collaborations. I've started the IORBC, which is the International Organization for Radiotherapy for Benign Conditions, at iorbc.com, and I would encourage you to join that because we do put out regular information. We are looking to develop collaborations with various societies, including ESTRO, ASTRO, and other national societies. Of course, education is key, and we are developing educational materials, including short introductions like this. We do need to protocolize things so that everyone's doing things to a high standard, and we will be developing common standards for this reason. And of course, we talked a little bit about the politics. We talked about naming rather than being called an oncologist. I think one really key thing is working out how this is funded. It might be that some people cash fund this, but of course, if governments get involved and they think that they might fund this to save money from expensive and invasive surgery, then that could be a very powerful way of getting this into the mainstream. Just going into a bit more detail about the evidence base. Generally, the evidence for benign radiotherapy is in case series, albeit quite large case series. For instance, for osteoarthritis, there are more than 13,000 patients in the literature. There are naming issues, not only with radiation oncologists, but also, for instance, with plantar fasciitis. Sometimes it's called heel pain. Sometimes the Germans call it calcaneodynia, so in other words, pain in the calcaneus. Sometimes they mix it up a little bit with plantar fibromatosis or with Achilles tendonitis. So it is sometimes difficult really to understand the literature. There are some randomized trials. Particularly the Dutch have done a trial for Ledderhose disease, which is like Dupuytren's on the feet, and they did a very, very good quality randomized controlled trial versus sham radiotherapy, which was positive. There are randomized trials looking at prophylaxis of heterotopic ossification, plantar fasciitis, and various other things. But I do feel that the particular area of research needed is in osteoarthritis and tendonitis. And of course, these things do need to be published so that people actually read them, ideally in English language journals rather than in textbooks or in German journals and conferences. Education and training for radiation physicians is really key. So I feel that we need upskilling in anatomy, pathophysiology, patient examination. I mean, personally, before I got into this, I hadn't examined a shoulder or an elbow for 20 years. So, you know, these are things that we need to upskill if it's not something you already do well. Looking at x-rays, that's not something I've done for a long time. Having liaison with referrer physicians, understanding the non-radiotherapy treatments, knowing how to make decisions as to eligibility for radiotherapy, and of course, radiation planning techniques. Even though that they are simple, we still need to know how to do them properly. This is pretty well my last slide. For the future, as I say, the IORBC is really important to join and be part of the community. I do feel that we need better research, and I'm at the moment developing education and training in this field. So thank you for listening, and I'll stop sharing the screen. Please do connect with me on LinkedIn. You're very welcome to email me to ask questions, but perhaps I could open up for questions and answers to the floor.
Thank you very much, Dr. Richard, for such an enlightening series presentation. So we open the floor for questions now. I think we have a few in the chat box. Still trying to. Someone asked a question on keloids.
Yeah.
I don't know. Can you type it again? Whoever the person is, I can't seem to find it. The fractionation and the dose for keloids, treatment of keloids.
Okay, so yeah, so I think. So do you want me to answer the question?
Okay. The question is, do you need surgery first before treatment of keloids? And if yes, what's the dose and fractionation?
Sure.
And
so
how soon after surgery?
Okay, so I think when we're talking about treating keloids, absolutely surgery is key. There is a small amount of evidence to treat keloids primarily with radiotherapy, but I would say that the evidence is, in my view, not good enough. You need to use quite high doses. Sometimes it does settle down the keloid, but there's no evidence looking about what it does in the long term. So in my view, if you're going to treat a keloid with radiotherapy, it does need to be post-operative. One really important thing to say is that the whole pathway of treating keloids needs to be done well. So, you know, treating an earlobe keloid is very easy. You know, you do an excision, and, you know, pretty well anything you do is going to stop it coming back. So often steroid injections can stop it coming back. But if you're doing something more complex, for instance, like a keloid on the anterior chest, where there's a lot of skin tension and a lot of movement, then actually that can increase the recurrence rate. So I work with a keloid surgeon who does tension relieving keloid surgery, and you often come out with sort of zigzag scars going quite wide across. This is quite a specialized area done by plastic surgeons. So I guess what I'm trying to say by that is that the surgery needs to be done in the correct way, because if you have a very tense scar, then it's more likely to recur. The radiotherapy ideally should be given within 24 hours of surgery, but I allow up to 48 hours. In terms of the dosing, everyone does different things. But I think the best papers that I've seen, and I'm happy to share this afterwards by email, is there's a Japanese group led by Ogawa, Ogawa, and they use as their standard dose 15 gray 3 fractions over 3 days. However, what they did over time is they were able to reduce the dose for low risk areas like earlobes in particular, and they had to increase the dose to high risk areas like the anterior chest, and they used 20 gray 4 fractions. And so I use that risk adapted approach, because if you've got a low risk area, you don't want to give too high a dose. If you've got a high risk area, you don't want to give too low a dose. So that's what I do. Different people just use sometimes a single dose for all areas, but in this sort of case series they did, I think it's proven that you do better if you adapt the dose to the risk.
Okay, so Dr. Richard, do you treat with photons or electrons?
For keloids, you can do either. I tend to use electrons just because at the moment I only have a LINAC rather than a superficial radiotherapy machine. I can't really see a reason why you would use megavoltage photons, because the penetration would be much too much. But if you have a kilovoltage machine, then I think that's also a very good way of treating keloids. And actually, I think that's probably logistically the best way of treating keloids.
Okay. Thank you. Yes.
You can answer. Right.
Okay, that's it.
Can we use megavoltage with bolus in areas where we don't have low voltage and electrons?
I'm really sorry. It was difficult to hear.
It's not audible. Can you hear me?
Yeah.
So my question is, in centers where we have mega voltage, can we use that if we don't have electric and photo voltage?
Sorry, it was very echoey, but I think what you're saying is you've got mega voltage, but you haven't got electrons and you haven't got kilovoltage. Is that correct?
Sorry, did you get the question before we chat?
So I think you have to shout. We're using this laptop to record you, not your phone.
Okay.
Right, so I can hear you.
Okay, the question again is, can we use mega voltage with bolus in centers where we don't have electrons and auto voltage?
I mean, my opinion is that that's not a good treatment. The reason being, you're particularly treating quite young patients typically for keloid scars, and you need to be really careful about radiation protection. And if you treat too deep, then you're going to give them a greater risk of radiation-induced cancer in the long term. And so, in my view, I don't think you should be treating keloids with megavoltage photons. Either electrons, where obviously you can control the depth well, or superficial orthovoltage treatments, where of course the penetration is less, would be the way to do it. If I only had megavoltage photons, I would just not treat keloids.
All right, thank you.
So I have a question about the use of benign radiotherapy. It appears that it's not yet as effective as it could be, or maybe not yet as widespread as it should be. Would that be a cost problem? Is it that there are alternative ways of treating osteoarthritis, for instance, so people tend not to bother with radiotherapy. Is radiotherapy, benign radiotherapy in particular, so highly priced that it's unaffordable when we compare it vis-a-vis with alternative treatments?
Yeah, I think it's a great reason. I mean, it comes back to that slide where I was talking about why benign radiotherapy is not more widely used. And I think that the reason why it's not more widely used is for many, many reasons. You know, I think a lot of it is social, cultural, political. I think just taking your example of osteoarthritis, you know, surgery is very widespread and surgery is very, very expensive as a treatment, you know, so I'm not sure that I really see, particularly in the UK, radiotherapy is much cheaper to deliver than surgery is. It does depend to an extent on what machine you're using, because of course, if you're using a Linac and, you know, it's cost you, I don't know, $1 or $2 million, and then you've got all the concrete shielding and the building, and then of course, you know, you've got a very high priced machine you're using. And so, you know, that big sunk costs and the staffing costs are going to make the treatment quite expensive. This is one reason why I'm so keen on superficial orthovoltage treatments, because, you know, the machine might cost you $200,000. You only need lead shielding, you don't need concrete shielding. You know, you need 1 or 2 radiographers, and it's very quick and easy. So, you know, I think radiotherapy can be given for different costs. I do feel that the reason tends not to be cost. I think it tends to be a lack of awareness, actually. And I think when people start doing this and they see the results of radiotherapy, that often radiotherapy starts to become more widespread. So, yeah, that would be my view. But of course, you know, what I would say is this is very dependent on the funding environment in different countries. And in some countries, it's paid by the government. In some countries, it's not paid by the government. In some countries, it's paid for well, and in some countries, not paid for well. Some people do this as a sort of private endeavor where patients paid by cash, and some people just do it on the public health system. So it's very, very variable throughout the world. I think, Victor, you're talking on mute. I don't know whether you are intending to ask a question.
Okay, I believe you can hear me now.
Yeah.
Okay, my second question was more about safety and the likelihood of a secondary malignancy. In fact, of a primary malignancy in this case, because the first tumor was not even benign, was not malignant in the first case. And what was the research around that? I know that, for instance, there are certain brain tumors that are benign, but have a risk of growth, and we treat it with radiotherapy. But what's the research in terms of the probability of a primary malignancy in this case?
Yeah, I think that's a great question, and I think it's a really key point actually that people wonder about. So the way I think about the risk of radiation-induced cancer when we treat benign conditions is there are a number of things that you need to think about. First of all, and this might seem obvious, is how much benefit are you going to give with the radiotherapy? Because of course, your threshold for treating will be different if you think it's going to give a lot of benefit or a little benefit. So that's just something to bear in mind. One of the main important things is what part of the body you're treating. And the question is, how much bone marrow is there in the area that you're treating? And how many other sort of organs that would be likely to form a malignancy? So, for instance, we've talked a little bit about the spine. That's where, you know, a lot of the bone marrow, of course, is in the spine and the ribs and the pelvis. And so we need to be very, very careful in those areas, because the risk of a hematological malignancy, particularly leukemia, not only is quite high, but also the latency period between using radiation and forming the leukemia might only be 5 or 10 years. So if you're treating even someone who's 60 or 70 years old over the spine, then, you know, they may well have a radiation-induced leukemia in their lifetime. So you have to be very, very careful in those areas. If you take something at the other extreme, as I said, you know, if you're treating the hand, the only real organs at risk there in terms of radiation-induced cancer is the skin in particular. So we talked about the risk of radiation-induced cancer of the skin. Really, that's a risk of a basal cell carcinoma, which of course doesn't really spread. You know, that risk for a 50-year-old, as I say, is a 0.1% lifetime risk. So that to most people seems acceptable. Of course, there's bone and soft tissue there as well. So for a 30 gray dose, you'd be looking at a risk of sarcoma, which would be roughly a tenth of the risk of a basal cell carcinoma. So that's a 0.01%, which in my view is very tiny. But there's no bone marrow there, so there's no risk of leukemia. And of course, you're not going to be giving a risk of breast cancer, lung cancer, etc. So those are the two extremes. And then in the middle, when you're treating areas like the shoulder for osteoarthritis or for rotator cuff tendinopathy, then there's a very small amount of bone marrow there. So if you're treating a whole shoulder, there might be roughly 2% of the bone marrow. And so, of course, that is a low risk. You need to take that into account. How old? So that's in terms of the site. In terms of the age, that's really important. If you're treating someone who's over the age of 60, generally, as long as you're not treating the spine, that is a very low risk for cancer. Whereas if you're treating a child, that would be very high risk. And personally, I do not treat children for benign conditions with radiotherapy, but I treat people from their 20s onwards. If I'm treating someone who's 20 rather than who's 60, I would have to talk to them very carefully about what the increased risk of radiation-induced cancer is. So site, age, dose is really important. So we try and reduce the dose as much as possible. For instance, for osteoarthritis, there were trials they used to use as their standard dose 6 gray and 6 fractions, and they did a randomized controlled trial looking at 3 gray and 6 fractions versus 6 gray and 6 fractions, trying to reduce the dose, and they found that they were equally effective, so they were able to reduce that dose. So we always try and reduce the dose as much as possible. And then last but not least, we're always trying to reduce the volume of tissue that we are treating as a general principle, and that might be to do with you know, reducing the field, reducing the volume, radiation protection in terms of lead, bolus, etc., etc. So, you know, I think those are the main issues that we need to think about. So, you know, there's not one sentence that I can tell you, you know, what's the risk. It depends what you're treating, what the dose, age of the patient, what part of the body, you know, we obviously need to reduce the risk as much as possible. So I know that's a little bit of a long answer, but I hope that's helpful in terms of a guide.
Right. Thank you. Mr. Asogwa, can you speak up now? Good morning, sir.
All right. Thank you. Thank you, our presenter, Richard, and thank you, the organizers, for this wonderful presentation. Yes, I'm sorry I joined late anyway, but at the point I came in, we're discussing about the use of electrons or auto-voltage machines for the therapy of benign tumors. Yeah, so from what I got from your explanation, so what we are talking about is the use of auto-voltage machine for this type of treatment, right?
Okay, so let me clarify. Different conditions need different techniques. And so, for instance, you know, really that question was about keloids. At least that's what I thought the question was. So I think, you know, cave-in electrons for keloids. If, however, you're treating someone for osteoarthritis, then the standard treatment would be with a parallel pair of photons. You can use, of course, megavoltage photons with or without bolus, and you can use kilovoltage photons, generally at around 200 kV, as a parallel pair as well. So, yeah, I think, again, it depends on what you're treating, what the anatomical site is, what the separation is, and what depth you're aiming to treat to. So I think all of these techniques have their place, but it depends on the particular type of treatment, you know, condition.
Okay. All right. Okay, that's actually clear, because I just wanted to be very clear about the particular kind of machines or the energy you are talking about. Because yes, I have seen an auto-voltage machine. There used to be one in Nigeria, but it's been decommissioned for a very long time. You understand? So we were even actually applying it for even chest wall treatment, where you are not dealing with a lot of depth in the tissue and all that. So, and the use of what is it called, low energy electrons 4 MeV, 6 MeV have actually given some good this thing. So I think it's okay. So just like you said, it depends on what you are dealing with that will determine, you know, what's your machine or energy you want to use. All right, thank you very much for the
Pleasure. Thanks for the question.
So, Victor.
Okay, thank you very much. Yeah, so I'm just trying to find out about the popularity of auto voltage machines. In fact, we don't have anyone in Nigeria, and
no, we
did. Okay, but we don't at the moment, you know. So I'm trying to figure out why that also is not popular. Is that because electrons have taken over, or maybe mega voltage can be used for some of these conditions, or the conditions are not as popular as they should be?
Yeah, I mean, I think that obviously it's difficult for me to say why you don't have many orthovoltage machines, but I think you know, people tend to think of orthovoltage machines being used for skin cancer in particular. And I don't know how much skin cancer you tend to treat compared to other types of cancers. I think that's one thing. The other thing is, if you have a LINAC anyway, then of course you want to use it as much as possible. And so people tend not to want to buy another machine. I guess my point about orthovoltage machines is, you know, it's not a choice. You don't have to choose between one or the other. It's just, if you wanted to start treating benign conditions, then this would be a much cheaper way of starting to do that. And the economics would make much more sense if you're, you know, maybe spending a few $100,000 rather than a few $1 million. You know, so that would be a very much more sensible way to get started to do this, assuming you don't have room on your Linux.
Oh, do we still have, what are the auto voltage popular ones in the market now? Because I remember what we had then at Abuja is called Pantac, you understand? And I know the problem that he had then, it was battery issue, that they couldn't find the battery again, and they were not able to charge and make use of the system. We had cones and all sort of collimation tools and all that. So what are the popular ones in the markets like today, if you are aware of them?
Yeah, I've just sent in the chat. It's a company called XStrahl, XStrahl, and you know, they are the market leaders, which is why I work with them. And these days the machines are much more reliable. Pantac was a very, very old machine, and they did tend to go wrong. The technology is just much more stable and better. So you know, that's for me the one that I would recommend. I wouldn't necessarily go with any others. And you can treat both low energies, you know, for keloids, and high energy for things like osteoarthritis, and so on. So you know, they're very versatile machines.
So what is your take about the use of this type of machine for chest wall treatments?
I've used so depending on what chest wall treatments you mean, maybe what you mean is gynecomastia with hormones for prostate cancer. That's what I used to use the machine a lot for.
No, I'm talking about mastectomy sites, you know, just treating the chest wall.
Yeah, so I mean, definitely they can be used. I think that you know, in our NHS, we would always treat these patients with LINACs because we have the capacity to do that for these patients. Obviously, it depends on your resource. It's better to use an orthovoltage machine than not to treat at all. But the problem with orthovoltage machines is, of course, you know, you will have disease going in, you will have radiation going more deeply into the lung or the heart, and that can cause problems in the future. So it would not be the first thing I would think about, but, you know, particularly for palliative breasts, it can be very helpful as well. It depends what you're doing, but, you know, if you're talking about adjuvant treatments to a chest wall after a mastectomy, then, which I think is what you're talking about, then probably orthovoltage would not be the first technique that I would be considering.
Okay, thank you very much.
Okay. All right, Ekene, your hand is up. Can you speak now? Ekene, can you unmute yourself and speak now? Okay. Okay, his question is, what is the imaging modality used to prep for the treatment? Used to prep for benign tumor treatment? Is it CT or MRI?
Okay, so again, this is a very wide area depending on what you're treating. I mean, if we take the main things that I treat, for Dupuytren's disease of the hand, really it's about examining the patient, finding out where the nodules and cords are, and essentially what I do is literally draw an electron field over much of the palm with a felt tip pen, and we work out the energy, we put some bolus, and it doesn't need any simulation at all. It doesn't need any diagnostic investigation either. If you're treating someone with osteoarthritis, often they may well have an X-ray, of course. If you're treating them with superficial orthovoltage treatment, they don't need any simulation at all. It's just clinical experience, really, that you define the field. So, on a shoulder, it would sort of be like this, and you just draw it off, and the radiation therapists will just reproduce that each day. If you're using a parallel pair with megavoltage photons, on a LINAC, then of course they would have a CT simulation, and that's where we would do that. As I say, it's very variable. It just depends what technique you're using. But with the orthovoltage machines, there's no sort of imaging simulation required. But of course, with the megavoltage machines, if you're using megavoltage photons, it's a CT sim. With electrons, you don't really need any simulation. It's just a clinical markup.
And this you want to speak, and unmute yourself. Okay, yes. Great. And
okay. Good morning, everybody. Thank you, ADMC, for organizing this. Thank you, Mr. Richard, for what you've explained so far. My question is, what is the imaging modality used to prep the patients for their treatment?
I think I just answered that, but just as a quick summary, for megavoltage, it would be CT simulation. For orthovoltage, it would tend to be just clinical markup, and for electrons, it would be clinical markup. But of course, it does depend what you're treating and what technique you're using.
I think that should be all for now.
Yeah, so again, arthritis, are we saying voltage? I see the single dose that you met during your presentation. So the megavoltage for arthritis.
I'm really sorry if that was a question. There was too much echo to understand again. Apologies.
Okay.
I said megavoltage, say for arthritis, use of megavoltage.
Yeah, I'm sorry. I'm just just the quality of sound is difficult to understand.
Yeah. Let's do it again. Right. Megavoltage, say for arthritis management. That's my question. Megavoltage usage.
Yeah, so for treating arthritis, it depends what part of the body you're treating. If you're treating a hand, either megavoltage parallel pair or orthovoltage will be fine. Once your separation gets to a certain level, for instance around 10 centimeters, then it might be that your 200 kV machine doesn't penetrate far enough with a parallel pair. So for instance, if you're treating a hip, particularly in a larger person, you would really need to use something like 6 MV photons and not use the orthovoltage machine. But depending on your case mix, most patients could be treated with orthovoltage, but everyone can be treated with megavoltage. So if you're using a LINAC, there's never a problem with penetration, of course.
Thank you.
Okay, Mr. Dan. No, I don't want to say that. Okay.
Still talking about conditions like osteoarthritis. How permanent is the cure or the result of the of the treatment, or is this something that has to be, repeated again and again, or does it give permanent cure?
So yeah, in terms, I think just to make sure I understand the question, when you're treating osteoarthritis, would you need to repeat it, and is it effective in the long term? I think that's the question.
Yes.
So with osteoarthritis, there's roughly a 75% response rate in terms of significant reduction in pain, and the data certainly goes out to at least a year or two in terms of that being the results. There isn't an enormous amount of long-term results, but in my experience, being in clinics in Germany, people can get significant pain relief. You can come back and have retreatment. So if you've only had 3 Gray and 6 fractions, that's a tiny dose. You could have that repeated. We tend to put roughly a 15 Gray limit on the amount of radiation that we'll give to each joint. So if you've used 6 Gray, then you can come back and have another 6 Gray, for instance. And there are sort of particular regimes that we would use to check that. So it absolutely can be repeated. But of course, there is a limit to each joint. One other thing I would say, by the way, is that there are also situations where I would not treat. If you've got a patient who's got a lot of pain and a grade 1, 2, or 3 osteoarthritis Kellgren-Lawrence score on an X-ray, in other words, they've got signs of osteoarthritis, but they've still got some cartilage and so on, then that would be a good indication to treat. If they've got a stage 4 where really it's sort of bone touching bone and no cartilage at all and a lot of deformity, then really surgery would be the thing to offer them, and radiotherapy would be much less likely to be effective.
All right, we can't take any more questions because our time is up. Thank you so much, Dr. Richard, for such a robust session and quite interesting and educative. We hope to have you again sometime in the future.
Be delighted.
Thank you so much. And thank you everyone for joining in. Our next series comes up on the 2nd Thursday in the month of April. The topic will be out in 2 weeks and the presenter too. Thank you so much, everyone. Thank you, Dr. Richard. It's a pleasure.
Thanks, everyone.
Thank you. Bye. Thank you, everyone.
All right. Thank you, everybody. Bye.